We'll now move to data aggregation across diseases and between stakeholders. Enrique Aviles, Director of Data Standards Management and Technology at the Critical Path Institute.
Thank you. Thank you. It's a real honor to be part of this workshop. This was the title that was given to my talk, but it really should say enhancing signal-to-noise ratio by combining data sets from multiple sources. So in CPATH, we have many different projects working together. And over the last 10 years, we've learned some hard lessons, developed some approaches to facilitate the sharing of data to support the aims of these consortia. I'll share with you a little bit of what we found has worked for us. Some key success factors. Before you even get to the data, it's structuring the collaboration in a way where there's very specific goals, an agreement on the value of achieving those goals, and also a defined structure and governance criteria for how members will work together. We found that members are more willing to share if they understand what are the rights of each member in the consortium, if there's a formal membership agreement, what will be done with the work of the consortium, how will it be shared and disseminated. And then, of course, you need to have the expertise. And by having multiple organizations working together, you get that critical mass of scientific and medical experts that you need to be effective. But you also need this whole spectrum of supporting disciplines. We found over the years that having those additional disciplines supporting the consortia make things work much more smoothly. Then into the data. Many times, the longest part of the process is the conversation about reaching an agreement for an organization to share data. So these factors play together. If there's a well-defined goal, specific rules on how members will work together and use each other's information that's contributed to the consortium, we find it's easier to get to that agreement to share data. And then you have to have this end-to-end process for having specific agreements for each data set, for working with the data in a consistent manner. Then having approaches to integrating the data sets that are considered scientifically valid, that give you that effect of enhancing the signal-to-noise ratio. So you've heard one example earlier today about the work on polycystic kidney disease where we use this approach. Later in the next panel discussion, there'll be detail presented about our work in Alzheimer's disease where we also use the same approach to get to a successful result, which was a new tool for drug development. So as far as sharing, what we found through this process of acquiring data sets to support our consortia, and we have one team at CPATH that supports all of our consortia, is that it really becomes, today it has to be a case-by-case situation. Every contribution is handled as a specific transaction with specific agreements on what can be done with those data, how broadly can they be shared, and also that the right work has been done to assure that privacy and anonymization are done correctly and the certification that that work is complete, or if there's additional work, agreement on how that will be done. Our approach to integration, how do we get these different data sets combined into one single unified data set? I'm not talking about data from different trials sitting in a database that can be accessed individually, but one combined data set, an integrated file, is to apply a consistent structure to those data. And for that, we've used the CDIS family of standards, which has been mentioned earlier. We didn't want to go create our own unique way of structuring information. We wanted to use a system of standards that is accepted and supported by the FDA, the EMA, the PMDA. So we partnered with CDISC, and that approach has worked for us. Along the way, as we're doing this process, of course, you have to have that expert input to make sure that as we're combining data sets that may be in different formats, that we're not doing something that creates inaccuracies or biases in the data. Once we have that master data set, we create analysis data sets that can be used by the working groups in each consortium to do their specific analysis. If the consortium decides to pursue a slightly different project, we can go back to that master copy and generate a different analysis data set. But we always maintain that master copy. And if there's ever a question on that standardized data set, we can go back to the source data. We always keep a copy as well of the data that has been contributed. We found that this approach really helps us because along the way, you will always find issues in a data set. You'll always have to work through and understand how to deal with that and come up with a solution that enables the project to move forward. Some key objectives that we always have on a data project, not just the consistent data structure, which to me is having an approach where you define a place for everything, everything in its place, but also that you maintain the utility of the data, that you are representing things in the smallest usable element of information because that gives you the maximum flexibility for analysis down the road. And then above all, and most important, is to maintain the integrity of the data. So do not alter the meaning of the data as you're doing this structuring and standardization approach. And so we have been successful in doing that. This has worked with it well for us. At times we've had to enhance our tools along the way, and we work with our partners to do that. So you'll hear more about the Alzheimer's example later this afternoon, but this is a project that went all the way to the endorsement of a new simulation tool for Alzheimer's. And you heard earlier about the polycystic kidney disease project, where we had data from multiple patient registries and observational studies that we followed this approach on. Also along the way, as we were working to standardize the data, we found gaps in the CETA standard. So we worked with CETA to enhance that standard, and that resulted in a publication of a supplement to their foundational standard. So improve the tools as you move forward and achieve your work. So as was mentioned earlier, this resulted in a qualification opinion from the FDA, and it's the work with the EMA is in its final phases with positive indications. At times, if the contributors agree that data can be shared more broadly beyond the initial objectives of the consortium, we will make data available where researchers that may not be members can apply, provide a justification for what they would like to do with those data, and then through a review and approval process are granted access to those data. Also, if possible, we make our tools that are developed available to the broad research community. And then beyond those examples, we are launching our first large foray into encompassing genetic data into our work with a major project on tuberculosis to develop rapid diagnostics for drug susceptibility. So taking the lessons learned from the past, enhancing our platform, and enhancing our tool set going forward to help the broader community. Then stepping back and thinking about some of the challenges that we've experienced and problems we've had to solve, these are some of the salient points for me, and some of these have been reinforced by my fellow panel members. One is the world of privacy regulations is getting more diverse and more complex. And we need to find ways to streamline that and have alignment so that it's easier to share data. So we need to get that turned around into a direction that is more efficient. Chuck Jaffe talked about interoperability for data standard systems. There's some good work going on today between the world of electronic medical records and clinical research. We need to do more, and we need to get ahead of it before we get flooded with all of the data from digital biomarkers that is coming at us. And then also, better incentives to encourage the more rapid and efficient sharing of data from academic research. In some cases, we have found that the longest conversations about getting agreement to share data are with academic institutions, not so with pharma, which you would expect it might be the other way around. So we've developed approaches to help researchers understand that their interests, their ability to continue to do research and publish on their work will be protected, but by participating in collaborative efforts, they actually gain benefits for them and also to help the overall project that they participate in. And then finally, where we have those success stories, highlight the value that can be gained from reuse of data. We have a few success stories at CPATH, others that you've heard about, which is great to see this all moving forward. We need to highlight those and then also learn from those to optimize approaches for new data collection efforts. So again, we keep building, growing, and enhancing. And then finally, help people understand the fact that the insights that you gain from working with data in these projects are enriched by using this process of integration. You really do enhance the signal-to-noise ratio by doing this. So thank you for your time and attention, and hopefully now we'll have a good panel discussion.